Hello, welcome to my channel. I'm Dr. Dravian Radiologist. This is a sonography-radiology training channel. I will present different videos could be benefit for physicians and general population. This is the sixth video about imaging findings in leukemia, mostly about thoracic imaging findings of leukemia and its complications. In this presentation, I will talk about these sections: lymphadenopathy, lung involvement, including leukemic pulmonary infiltration, pulmonary leukostasis, leukemic cell lysis, hyperlococytic reaction, pleural involvement, and heart involvement, and also myeloid sarcoma, amyloidosis, including lung, pleural, airway, and cardiac involvement, role of PET-CT, and final teaching point. You can see this section in video part 1 and this section in video part 2. Lymphadenopathy is the most common manifestation of leukemia in the thorax. Leukemia also may involve the lungs, pleura, heart, bones, and soft tissues. The first section about lymphadenopathy. Mediastinal lymphadenopathy more common in the lymphoid leukemias than in myeloid leukemias and is visible radiographically in about 25% of CLL, about 10 to 20% of ALL, and 5% of AML and CML. In this coronal CT image, we can see lymphadenopathy in 71-year-old woman with CLL. Coronal CT image shows mediastinal and right hilar adenopathy and also left axillary lymphadenopathy. Hilar lymphadenopathy occurs less commonly. Patients with ALL can present with a large symptomatic anterior mediastinal mass. Axillary lymphadenopathy is most common in patients with CLL, about 42 to 54%. Now a case presentation of leukemia with mediastinal lymphadenopathy. In this axial CT image, in a 57-year-old man at the aortic arch shows adenopathy at both axilla in the left internal mammary region and throughout the mediastinum. Workup reveals T-cell leukemia, and cytologic evaluation of left pleural effusion also reveals leukemic cells. Another case, a 13-year-old girl with acute lymphocytic leukemia presenting with mediastinal mass and stridor. In this chest CT image, there is a large anterior mediastinal mass displacing the vascular structures and reveals compression and displacement of trachea, marked narrowing of left main bronchus, and precordial effusion. In a 3D reconstruction of the airway, compression of the left main bronchus is clearly seen. For diagnosis of lymphadenopathy, the first choice is chest X-ray, which confirmation must be done by CT scan. Differential diagnosis, of course, is lymphoma. The next segment is lung involvement. Pulmonary complications in patients with leukemia are often due to pneumonia, hemorrhage, edema, or drug toxicity. However, there are several causes of pulmonary disease that are directly related to leukemia, including leukemic pulmonary infiltration, leukemic leukostasis, leukemic cell lysis, and hyperlococytic reaction. The first part is leukemic pulmonary infiltration. What is the definition of leukemic pulmonary infiltration? Extravascular collections of leukemic cells in the lung parenchyma without another apparent cause for their presence. For example, infection, hemorrhage, or venous congestion. Occurs most commonly in the terminal stage of the disease, but also may occur at other time points, including before treatment. Now, a case presentation of leukemic pulmonary infiltration. Leukemic pulmonary infiltration in a 23-year-old man with relapsed AML. In this axial CT, we can see a nodular lesion in the left lower lobe. At autopsy of this patient, multi-organ leukemic infiltration was found, including involvement of the left lower lobe. Autopsy studies have found leukemic leukemic pulmonary infiltration in more than 25% of leukemic patients. Leukemic pulmonary infiltration is not often evident radiographically. What is CT finding of this entity? CT finding of leukemic pulmonary infiltration non-specific. However, leukemic cells have a tendency to involve the peri-lymphatic interstitium, producing smooth or nodular thickening of bronchosvascular bundles and interlobular septa. Like this case of leukemic pulmonary infiltration in 53-year-old man with T-cell ALL, which we can see thickening of bronchosvascular bundles and interlobular septa in the right lung, findings that are consistent with lymphadenopathic spread of leukemia. Also, note the loculated right pleural effusion, which thoracosynthesis revealed numerous blood cells consistent with leukemic involvement. Nodules are also common and may be peribronchovascular, centrilobular, or random in distribution. In this axial CT image in a 41-year-old man with ALL, axial CT image for reassessment of pneumonia, which diagnosed 2 months earlier, shows that the pneumonia is resolved, but there are multiple new nodules that are suspicious for fungal pneumonia. But pathologic specimen revealed that these findings consistent with B-cell acute lymphoblastic leukemia. Another CT findings are ground glass and consolidative opacities are also common. The consolidation may predominate in peribronchial regions, reflecting infiltration of the parenchyma adjacent to peri-lymphatic interstitium, like this case of leukemic pulmonary infiltration with multiple ground glass and consolidative lesions. Now a case presentation, 67-year-old woman with adult T-cell leukemia. This chest X-ray shows focal areas of consolidation in left upper, left lower, right lower lobes. This HRCT image targeted to the right lower lobe shows consolidation in peribronchial distribution. Another case, 45-year-old woman with adult T-cell leukemia. HRCT reveals peripheral focus of consolidation within posterior segment of right upper lobe. Note smaller foci of consolidation within upper and lower lobes. Also note ground glass opacities that fill secondary pulmonary lobules with a panlobular distribution. Also, CT finding may be suggestive of leukemic pulmonary infiltration, but accurate diagnosis usually requires bronchoalveolar lavage or lung biopsy. Another type of lung involvement is pulmonary leukostasis. Leukostasis, a condition that results from accumulation of leukemic cells in the small vessels. Symptoms are the result of vascular occlusion and obstruction. Leukostasis can involve any organ, however, the lungs and the brain are affected most commonly. More common in AML, but also seen in the blast phase of CML. Leukostasis occurs in patients with very high white blood cell counts, usually between 100,000 per cubic millimeter and 500,000 per cubic millimeter. Imaging findings in pulmonary leukostasis may be normal or may resemble interstitial or alveolar edema. Edema in pulmonary leukostasis is thought to be secondary to increased capillary permeability edema related to the abundance of leukemic cells or cardiac failure from coronary artery leukostasis. Now a case presentation of leukostasis. Leukostasis in 9-year-old girl with AML, fever, blood cell counts of 80,000 per cubic millimeter with 83% blood cells. Admission chest radiograph is normal. In the hours after admission, the patient developed rapidly progressive acute respiratory failure and her white blood cell counts increased to 136,000 per cubic millimeter. Chest radiographs shows diffuse bilateral opacities. The clinical findings were consistent with leukostasis and the patient underwent emergent leukapheresis to achieve leukodepletion and elevate leukostasis. Leukostasis occurs most commonly in acute myeloid leukemia. Another type of lung involvement is leukemic cell lysis. Leukemic cell lysis pneumopathy is an acute respiratory distress syndrome that occurs within 10 to 48 hours after the initiation of chemotherapy in patients with high leukocyte counts, generally beyond 200,000 per cubic millimeter, with 70 to 90 blasts. Leukemic cell lysis pneumopathy occurs most commonly in patients with ALL. Radiologic manifestations are those of acute respiratory distress syndrome and include extensive bilateral aerospace consolidation. Now, a case presentation. Chest X-ray reveals diffuse bilateral pulmonary infiltrates and pulmonary vascular congestion. By histology, these infiltrates were proven to be of leukemic origin. And the last type of lung involvement is hyperlococytic reaction. Hyperlococytic reaction, an acute respiratory distress syndrome in which the appearance of respiratory distress parallels a rapid increase in leukocyte counts and the number of blast cells. The doubling time of the leukocyte count is less than 5 days, and with an average of 2.5 days. At the time of respiratory distress, patients have marked leukocytosis beyond 125,000 per cubic millimeter and a high percentage of circulating blasts, about 35 to 100%. Radiographically, a hyperlococytic reaction manifests with bilateral areas of consolidation. As with leukostasis, a hyperlococytic reaction is more common in AML and in the blast phase of CML. Now, a case presentation of hyperlococytic reaction. This chest X-ray shows small bilateral pleural effusions and left lower lobe aerospace opacities. A CT scan performed 9 hours later shows small bilateral pleural effusions, consolidation in the left lower lobe and lingula, and a small precardial effusion. Also, there were additional findings which we cannot see in this presented image. In the second patient, the radiograph showed a small left pleural effusion and aerospace opacity along the periphery of the left mid-lung. A CT scan obtained 5 hours later showed small bilateral pleural effusions and small aerospace opacities in the lingula and the right lower lobe. Another section of thoracic imaging findings of leukemia is pleural involvement. At autopsy, pleural involvement found in about 21% of patients with leukemia. Most common in ALL, pleural and pulmonary infiltration may coexist. What is manifestation of pleural involvement? The most common manifestation is pleural effusion. Another finding are pleural masses or thickening, or a combination of the two. Pleural effusion more likely to be benign than malignant, may be related to therapy, may occur in patients with graft versus host disease, a potential complication of hematopoietic stem cell transplantation. Now, a case presentation of pleural involvement. Pleural leukemia in a 40-year-old man with ALL. Axial chest CT shows bilateral pleural lesions, which pleural biopsy results confirm the diagnosis of ALL. Another case, pleural leukemia in 65-year-old man with CLL. Axial contrast enhanced chest CT image shows right pleural effusion and also pleural thickening, and adenopathy in the axilla and mediastinal. Another case, pleural leukemia in an 81-year-old man with relapsed AML. Chest radiograph reveals lumbral left pleural and extrapleural opacities, and axial chest CT shows multiple left pleural masses consistent with leukemic involvement. The last section in this part of thoracic imaging findings of leukemia is heart involvement. Leukemia can involve all components of the heart, including epicardium, myocardium, and endocardium. At autopsy, about 11 to 37 of patients with leukemia have heart involvement. Patients with leukemic cardiac involvement are frequently symptomatic. A case presentation of heart involvement. In this image, precardial leukemic involvement in 27-year-old man with T-cell leukemia who presented with chest pain. We can see precardial effusion and precardial nodularity. What is manifestation of heart involvement? The most common manifestation is enlargement of cardiac silhouette due to cardiomegaly or precardial effusion. In leukemia, enlargement of the heart due to neoplastic involvement itself is uncommon. Cardiomegaly is much more likely to be secondary to anemia or heart failure. The second manifestation is cardiac rhythm disturbances, and the third one is constrictive pericarditis. A case presentation: a 57-year-old man with CLL who presented with increasing dyspnea. Chest X-ray showed massive globular enlargement of the cardiac silhouette, which is consistent with precardial effusion. Echocardiography revealed tamponade, and the patient underwent emergency precardiocentesis. The cause of precardial effusion was multifactorial and related to end-stage renal disease and leukemic involvement. Precardial biopsy of this patient revealed CLL. Precardial effusion more likely to be benign than malignant. We can see heart involvement with cardiac mass. A rare manifestation is seen only as a case report, mostly after chemotherapy or bone marrow transplant, whereas one case reports a right-sided cardiac mass at initial presentation. Now, case presentation of heart involvement: a rare case of peribasal ALL with cardiac mass, chest X-ray showing enlarged heart with left-sided pleural effusion, and transthoracic 2D echocardiography in apical four-chamber view showing mass in the right atrium extending into the right ventricle. This contrast-enhanced chest CT from the same patient showing intracardiac large hypoattenuating lobulated soft tissue mass lesion adherent to anterolateral wall of right atrium infiltrating the arterial wall as well as atrioventricular septum. Teaching point of heart involvement: leukemia can present as a cardiac mass and should be considered during workup of patient presenting with chronic fever and right-sided heart failure. Early diagnosis by a combination of imaging and biopsy followed by early initiation of treatment may alter the course of this malignant disease. On the other hand, heart involvement may be due to chemotherapy-induced cardiac toxic effects, with which its manifestations are variable and include congestive heart failure, cardiomyopathy, and pericarditis. If you like this video, please subscribe this channel. If you would like to get notification for the next videos, please press the small bell. If you have any question or video suggestion, please write in the comments. Thank you for your attention.